स्टार्ट किया जाए।
Very good afternoon to all the participants for the webinar today. This webinar is being live telecasted at YouTube, and we have with us our Additional Chief Secretary, sir. We have with us State Nodal Officer for Home Isolation and Training, Sri Bhunesh Pratap Singh. We have also with us expert panel of doctors who will be making presentation on various topics. I welcome Additional Chief Secretary, sir. I welcome Sri Bhunesh Pratap Singh. I welcome Dr. Rajesh Kumar, Secretary, Indian Academy of Pediatrics. I welcome Dr. Saktipad Das, Pediatrician. Professor Dr. Kiran Das, Department of Neonatology, RIMS. Dr. Preeti Dubraj, Department of Neonatology. Dr. Apeksha Pathak, Dr. Sumant Misra, Dr. Rahul Kapse, Dr. Ganesh Mathur, and Dr. Amren.
ये टाइम लैग आ रहा है इसमें।
The brief minutes of the meeting would be as such immediately after the keynote address from Additional Chief Secretary, sir. There will be a discourse on management of COVID-19 in children aged 0 to 2 years, 13 in children aged 2 to 18 years by Dr. Preeta. Use of ventilators in severe COVID-19 newborn and particularly among newborns and pediatric age group would be done by Dr. Rajesh Kumar and Dr. Apeksha Pathak. Followed by this, there will be open group discussion since we have more than 40 to 45 pediatricians from different districts, both from the government as well as from the private sector who are attending this. One of the important reasons for having this meeting is a cause of concern among all of us, especially those concerned with public health service delivery, with respect to a possible third wave of COVID-19, which may have the potential of affecting the newborn and the children. As we have noticed that there are already information that the variants by the name B.1.617 and B.1.6.618 have been affecting the children in some parts of the world. And now that there has been mutation in the spike protein of the virus, which has the potential of being easily attached to the receptors, even in the case of children, which was not present earlier due to a lack of ACE receptors availability among the children. So, considering these facts and considering the fact that we need to have a good setup of pediatric ICU and as well as trained doctors who can handle the cases, both with confidence as well as with knowledge. So this is a broad objective perspective behind this meeting. Now, sir, with your permission, I would request State Nodal Officer, Dr. Bhunesh Pratap Singh, to kindly give a brief outline of today's video conferencing and at the same time the expectations that we have from the VC.
Thank you, Ravi. Am I
Please.
audible, Ravi? Am I audible, Ravi?
Yes, sir.
Yeah. Thank you, sir. Good morning. Good afternoon, sir. I welcome ACS, sir. I welcome MD NHM, all the pediatricians who are there with us in the group, and all the persons who have joined us, who are seeing us on YouTube about this. Before beginning, first of all, I'll say thanks to our ACS, sir, जिन्होंने एकदम से इस चीज को सर ने अंडरस्टैंड किया कि अगर थर्ड वेव आती है तो किला को कैसे मजबूत किया जाना है। इसके लिए मैं सर को आभार व्यक्त करता हूं, क्योंकि ये बहुत इंपॉर्टेंट चीज है। सेकेंड वेव में हम लोगों ने देख लिया है कि किस तरीके से हम लोग एज अ स्टेट, एज अ नेशन हम लोग ब्लीड कर रहे थे। और ये जो अभी सर का प्लानिंग है कि हम लोगों को अभी से ही प्लान करना होगा कि आगे हम लोग कैसे बढ़े। अगर हम लोग किसी भी एपिडेमियोलॉजिकल स्टडीज के द्वारा देखें और हम लोग जितने भी अभी मॉडल्स मार्केट में आ रहे हैं उनके अनुसार एक्सपेक्ट करें तो जुलाई से लेकर अक्टूबर के बीच में अगर कोई थर्ड वेव आती है तो आएगी। उसकी कोई श्योरिटी नहीं है थर्ड वेव आएगी या नहीं आएगी, लेकिन जिस तरीके से हमारे देश में वैक्सीनेशन ड्राइव चल रहा है, हमारे राज्य की जो पॉपुलेशन है, आप सबको पता है कि 3.25 करोड़ पॉपुलेशन है, जिसमें 18 से 44 ग्रुप में तकरीबन 1.74 करोड़ लोग हैं। और हमारे पास जिस तरीके से वैक्सीनेशन अवेलेबल हो रही है, सो वी विल बी मतलब बाय द टाइम जुलाई आएगा हम 100% लोगों को वैक्सीनेशन नहीं करा पाएंगे बाय ऑल द प्रोबेबिलिटी। तो हम सब लोगों को अभी से ही तैयार होना होगा कि किस तरीके से हम अपने पीडियाट्रिक एज ग्रुप में अगर आता है कोरोना तो हमें स्ट्रेटेजाइज करना है, रेडी होना है। इस बार के कुछ लेसन हम लोगों को थे, जैसे मैं आप सबको एट द वेरी आउटसेट बताना चाहूंगा कि हमारे सारे पीडियाट्रिशियन से मेरा आप सबसे अनुरोध है कि आप लोगों के जो भी आइडियाज हैं, अभी एसीएस सर ने कल हम लोगों के साथ मीटिंग की थी और सर ने एक हम लोगों को डायरेक्शन दिया है कि हम लोग एक मैनुअल ऑफ थर्ड वेव किस तरीके से टैकल करेंगे, मैनुअल ऑफ हाउ टू टैकल थर्ड वेव इन झारखंड, वो हमें प्रिपेयर करना है। उसके लिए मैं चाहता हूं कि इंस्टेड ऑफ बिकमिंग अ मैनुअल बाय 3 और 4 डॉक्टर्स, कि हम 5-6 लोग मिलके बनाएं। स्पेशली अडल्ट वाले में कि अचानक से रेमडेसिविर की डिमांड बढ़ी, फिर अचानक से अलग अलग दवाइयों की डिमांड बढ़ी। तो आप लोगों को जब भी पता है कि कौन कौन सी दवाइयां हम लोगों को आवश्यक पड़ेगी, मेरा आपसे अनुरोध है कि आप अपनी हर तरीके की स्टडी कर लें और हर तरीके का जो थॉट आप लोगों के मन में आएगा, बिकॉज अभी वी आर प्रिपेयरिंग फॉर इट। एंड कल एसीएस सर ने हम लोगों को बहुत अच्छा सुझाव दिया कि व्हेन यू आर प्रिपेयरिंग फॉर द वर्स्ट, और हम लोगों को अपनी ऐसी फैसिलिटी बनानी है कि अगर हम आज भी इसका नाम का कोरोना नहीं भी आए तो हमारी फैसिलिटीज हमारे साथ हो जाए। मेरा आप सभी लोगों से अनुरोध है कि आप लोग अपने जो जो ड्रग्स आपको लगते हैं होना चाहिए, हमारे पाठक जी हमारी टीम में हैं, हमारे साथ हमने प्राइवेट हॉस्पिटल्स के डॉक्टर को भी ज्वाइन कराया, रानी हॉस्पिटल के डॉक्टर साहब हैं, सहाय जी हमारे साथ हैं, बहुत सारे लोग हैं। आप सब लोग अपने व्हाट्सएप करके हमें पर्सनली, एमडी साहब को पर्सनली आप भेज सकते हैं, आपकी आइडियाज और प्लान्स को हमारे पास भेजिए। कि और मैं चाहता हूं कि एक जन भागीदारी से, स्पेशली डॉक्टर्स की भागीदारी से और अंडर द लीडरशिप ऑफ अवर एसीएस सर, जो थर्ड वेव पे जो हमें शंका है वो आए ही नहीं, और इनकेस अगर वो आती है तो हम लोग इतने प्रिपेयर्ड रहें कि एक भी बच्चे की जान ना जाए। ये हमारा एक आउटलाइन है। मेरा आप सबसे अनुरोध है, इसमें आप लोग डिस्कशन भी करेंगे। सेकंड मेरा आपसे अनुरोध है, जो हमारे सरकारी हॉस्पिटल के डॉक्टर्स हैं, कि चाइल्ड फ्रेंडली हॉस्पिटल इनिशिएटिव का भी सर के साथ कल डिस्कशन हुआ। मैं चाहता हूं कि आप लोग इसमें भी अपना दिमाग लगाएं। सारे डॉक्टर्स बहुत इंटेलिजेंट होते हैं, आप लोगों की जो क्रिएटिविटी होती है बहुत हाई होती है, मैं आप लोगों से चाहूंगा कि आप इस तरीके के आइडियाज बताएं कि ऐसा, क्योंकि देखिए अभी जो 18 साल से ऊपर वाले लोग हॉस्पिटल में आ रहे थे, उनको पता था कि कैसे अपनी इम्यूनिटी से लड़ना है, लेकिन जब हमारा बच्चा जो आ रहा है उसको नहीं पता है कि हम कैसे लड़ेंगे, स्पेशली 2 साल से 10 साल का बच्चा या 10 साल से 18 साल का भी बच्चा, तो उसको हमें ये फील ही नहीं कराना है कि उसको कोरोना है या कोविड के कॉम्प्लिकेशन है जिस चक्कर में वो हॉस्पिटल में है। उसको हमें हमेशा ये फील कराना है कि ये तो छोटी सी बीमारी है, एंड दिस टू शैल पास। तो इसको किस तरीके से हो सकता है, तो इसका एक आइडिया सर के साथ कल हम लोग डिस्कस कर रहे थे कि हम ऐसे हॉस्पिटल्स बनाएं कलरफुल, जिस रूम में भी हमारे बच्चे को हम एडमिट करें इतना कलरफुल होगा, क्योंकि बच्चों को कलर्स बहुत पसंद है। आप सारे, मैं पर्सनली बहुत सारे अपने छोटे बच्चे को दिखाने जाता हूँ, आप लोगों के पास ही आते हैं, तो आप लोग, हम लोग बच्चे को चुप नहीं करा पाते, लेकिन एक छोटा सा डॉल दिखा करके आप लोग बच्चों को चुप करा देते हैं। इस तरीके के बहुत सारे आइडियाज आप लोगों के पास हैं, मैं चाहूंगा कि आप लोग अपने आइडियाज हम लोगों के साथ शेयर करें। इसके अलावा भी किस तरीके से हमारे पास जो प्री एग्जिस्टिंग फैसिलिटी है उसको हम लोग कैसे यूज करें, ये भी आप लोग हमें सजेशन करें। एंड आप बिलीव में एसीएस सर के पास बहुत सारे आइडियाज हैं, मैं ज़्यादा आप लोगों को बिल्कुल टाइम नहीं लूंगा। एंड मैं चाहूंगा कि आप लोग सर को ध्यान से सुने। मेरा बस आपसे यही अनुरोध है कि आप लोग हमें पर्सनली व्हाट्सएप कर सकते हैं। ओवर अ पीरियड ऑफ नेक्स्ट 2 to 3 मंथ हमारे पूरा स्टेट आप लोगों के साथ है, और हम सब लोग चाहेंगे कि किसी भी तरीके की अगर कोई दवाइयाँ हैं, आप लोग अपने डिस्ट्रिक्ट में ड्रग इंस्पेक्टर हैं, आप हमको बताएं, वो सारी दवाइयों को हम लोग आने वाले समय से पहले ही प्रोक्योर कर लेंगे। और इसमें कोई प्राइवेट और गवर्नमेंट डॉक्टर का हम लोगों ने डिफरेंशिएशन नहीं किया है। हम चाहते हैं कि दोनों प्राइवेट और गवर्नमेंट के जो डॉक्टर हैं हमारे साथ कदम से कदम मिला करके, अगर कोई थर्ड वेव आती है तो हम कोशिश करें कि एक भी बच्चा हमारे का डेथ ना हो। विद दिस आई थिंक दिस इज माय वेलकम स्पीच टू ऑल ऑफ यू, and I expect and request you all to participate with us fully. And thank you very much, Ravi. Over to MDNH.
Thank you so much for laying out outline for this meeting. Sir, I will request you to kindly lay down the broad principles as we have already discussed under your guidance, sir. So if it can be presented before all the participating doctors, it will be both motivational as well as it will clearly set out the objective for the time to come. Sir, please.
Thank you, Ravi. Members from the expert panel, Dr. Rajesh Kumar, Dr. Shaktipat Das, Dr. Kiran Das, Dr. Rahul, Dr. Vanesh, Dr. Amrit, which we anticipate we were caught unawares as far as second wave is concerned. And it was a very difficult and uphill task for us to handle the crisis situation which had erupted. But with all your hard work and your knowledge,
ठीक लिखा हुआ सर, वर्ड
सबसे कैसे वो बहुत मुश्किल है
So please just wait, KJ. I think there is some connection error. Let me talk to them. There is some network error. आप लोग please एक मिनट wait कीजिए. I'll just talk to sir and get back to you.
In between, sir, I request you to kindly continue. I was talking about the
rural areas, the strategy which we have evolved to control spread in rural areas, and how the Jhola Chap doctors, they are creating confusion and guiding the patients that they are being affected by that casualties. At one point of time, as you are all in that prevention is better than cure. And infrastructure and facilities for the I am pleased that around 50 participants are participating in this webinar. And we'll be holding another webinar very soon, in which Honorable Chief Minister also would be participating, and we would be having experts from across the country. International experts also. I am trying. Had presented, we intend to have a multi-pronged strategy of how we will be handling this age group, because this is the only age group which has not been affected so adversely by this crisis. And the virus is continuously changing its genetic sequencing. We have requested for a genome machine also, so that, but that will take time, but we have to prepare ourselves that how and what sort of impact it will have on this age group between 2 to 18. We can categorize 2 to 18 age group into two categories, from 2 to 10 and then 10 to 18, for which we can have different strategies. What sort of infrastructure we have, what sort of equipment is required, or what all medicines are to be procured so that we have a stock of medicine in case such tragedy comes to us. The requirement of paramedical, the requirement of doctors, the training of, because I am not sure whether we have so many experts in this sector. So we'll have to take up the training of paramedical and enlightening the doctors regarding this aspect, as very rightly mentioned about the psycho child when he goes to fight corona, and we add to it. So this webinar is rolling out of the initiative which we are going to start, and the experts would be presenting on various issues, the management of COVID-19 in children between 0 to 2 years, between 2 to 18, the use of ventilator in severe COVID-19 newborn, and pediatric. So all these issues would be by the experts in this sector. And after that, we'll be having a discussion. And we are open to all discussion. Nothing is impossible if we are prepared in advance. Then it is very easy to handle, because no question is out of syllabus. We know what all questions can be asked, what all sort of problems may erupt. And if we are prepared for all sort of permutations and combinations of problems, then perhaps we are better able to handle it. So, not taking much of time, I would request Ravi to take ahead this webinar and request for the first presentation. Thank you very much. And you have spared so much of your precious time, for which I am thankful, and would be expecting much more inputs from you in future. Thank you.
Thank you so much, sir. Would be encouraged to take forward the required steps to mitigate of the third wave on the children in particular, sir. Now, with your kind permission, sir, I will request Kiran has a brief presentation on the management of
हेलो हाँ कहाँ आ नहीं रहा है सर स्क्रीन में स्क्रीन में तो नहीं आ रहा है सर। हेलो, हम एसेंसियो रिम्स, हाँ हाँ एसेंसियो रिम्स, नहीं म्यूट तो नहीं, अनम्यूट किया हुआ है, लेकिन वो मेरा प्रेजेंटेशन नहीं आ रहा है स्क्रीन में। हाँ मेरे को तो नहीं दिख रहा है। अब क्या आ रहा है? यहाँ पे तो किन्हीं के पास नहीं आ रहा है, जो साक्षी भी है। हाँ पीपीटी नहीं आ रहा है। हाँ वो किन्हीं को भी नहीं दिख रहा है सर, किन्हीं को भी नहीं दिख रहा। क्या बोला? वेलकम करना है सारे सर लोगों को, हमको तो कुछ नहीं बोलना है।
डॉक्टर साहब आपको स्क्रीन दिख रही है अभी?
नहीं सर वो पीपीटी नहीं आ रहा है सर, स्क्रीन नहीं आ रहा है।
पास भी करा लो, सब करा लो।
अभी आया था, अभी आया था।
तो योजना विभाग में चाहिए था मुझे।
राजवीर विराजी का क्या?
स्लाइड छूट रहा है।
डॉक्टर साहब अभी प्रेजेंटेशन शेयर कर दिया गया है, आप काइंडली अपना माइक अनम्यूट करके और प्रेजेंटेशन स्टार्ट कर सकते हैं।
अनम्यूट कीजिए। हाँ अनम्यूट कीजिए।
Yes, thank you sir. Now I like yes. Now I like to talk the topic the management of COVID-19 is 0 to 2 years. Next.
Next.
Transmission is born from the mother can occur through the intrauterine route, intrapartum, or postpartum. This is the very through the intrauterine, the transplantation, placental hematogenous spread and amniotic fluid through intrapartum transmission from the maternal infected secretions or feces. In postpartum, the infected mother, family members, and through the healthcare worker, there is a transmission, and transmission more likely from the respiratory secretions and less likely from the breast milk. Next. The learning objective of today's presentation is the challenges is neonatal care during COVID, clinical importance of COVID-19 in neonates, and delivery room care, how we'll do roaming in, breast milk feeding and KMC, what is the importance, how we'll do immunization and communication and counseling with the family members during the COVID and protection from the COVID-19. Next. The challenges that we are facing during the newborn care during the COVID, there is a disruption of standard neonatal care. The standard neonatal care practice, which we are doing normally, it is disrupted in COVID situation. But like delayed cord clamping, skin to skin care, roaming in, breast milk feeding, family access and communication and counseling. And there is also challenges for the family. There is a how to assess the hospital and doctors. Parent-infant bonding is hampered and family participation, disruption in the follow-up during the COVID and immunization, where to do the immunization, when to do, and there is an increase. All this make the parents and the family stressed. The challenges for the healthcare team, there is a fear and stress how to tackle the newborns and pediatric patients and how to wear, how to protect myself. The availability of PPE kit is there or not. And mental supports. These are the challenges that we are facing during the COVID-19 during the care of the newborns or in pediatric patients. Next. The clinical importance is just, I said that there is a 3 mode of transmission, the intrauterine, intrapartum, and the vertical transmission is extremely rare. Intrapartum and postnatal transmission occurs commonly, but it is preventable with simple measures. So by doing the simple measures, we can prevent the intrapartum and postnatal transmission. Most of the infected neonates are asymptomatic or have symptoms related to prematurity and its complication. It is seen, we have seen in our last COVID, the most of the infants are asymptomatic and they did not present with any symptoms. And the most of the symptoms relate to the prematurity and its complications. Next. Why there is a less or milder illness in neonate because of immature immune system. There is a passive transfer of IgG antibodies from the mother to the children, and there is a lower AC2 expression in the placenta or in the there is an incubation period from the 2 to 14 days. The median incubation period in the neonatal COVID is 5 days, and the test we are doing here, like RT-PCR of nasal, either nasal or nasopharyngeal or the throat swab or both. Next. The COVID-19 pneumonia is being seen more commonly in this wave, and the other inflammatory syndrome have been reported in neonates. Effects of COVID-19 in the first trimester on the fetuses are not well known. Next. The clinical manifestations we categorize in early onset or late onset, but there is a no clear-cut definition of early onset or late onset. Early onset, thus we are suspecting in within 1 to 3 days, somewhere it is written in 5 days. That means if there is a transmission, there is a vertical transmission. If baby presents early in one early onset, the baby can present with lethargy, respiratory distress, temperature instability, refusal to feed, or bluish discoloration of the hands and feet or whole bodies. There is a no clear-cut definition, just said early onset. Early onset clinical features are mostly represent the vertical transmission of the if it occurs late, like after the 5 to 7 days, then it is said that the infection may occur from the mothers. That means the mother is not taking the proper respiratory precaution during the baby care, and the presentation may be lethargy, respiratory distress, temperature instability, or apnea. Multi-system inflammatory syndrome in newborn is extremely rare, but it is seen. So we have to prepare and we have to know about the multi.
डॉक्टर साहब, we are losing your voice. आपकी आवाज clearly नहीं आ रही है डॉक्टर साहब.
Yes sir. हाँ. अब आ रही है सर? Hello.
Yes, yes, go ahead.
Still, majority of symptomatic have mild moderate disease and improve with PPT. जी सर, वो PPT गायब हो गया.
आवाज आ रही, बोलिए सर. देखिए ना.
डॉक्टर साहब, आई विल रिक्वेस्ट यू कि आप कंटिन्यू कर रहे हैं. मीनवेल हम प्रेजेंटेशन भी आपका लगा देंगे. ठीक है डॉक्टर साहब, बिकॉज लेट अस नॉट मेक पीपल वेट फॉर हियरिंग अस. आप अपना ऑडियो ऑन कर लीजिए, आपका हम तुरंत लगा देंगे थोड़ी देर.
So suppose there is a call from the delivery room, there is a COVID delivery room, or there is a COVID OT. So how to prepare the delivery room? The precautions, what are the precautions we take in delivery room? So there is a resuscitation corner at least 2 meters away from the delivery area. And those who is going for the resuscitation is fully prepared with PP kits, and the mother should also wear the triple layer surgical mask, and during intubation or suction there is a plexiglass head box or face shield should be there. Delivery room, please. Next, sir. Next.
डॉक्टर साहब अभी आपको प्रेजेंटेशन दिख पा रहा है?
हाँ, ये सर दिख रहा है सर. नेक्स्ट स्लाइड सर. Next. हेलो सर.
डॉक्टर साहब आप कंटिन्यू करते रहिए, हो सकता है टेक्निकल इशू हो, आप यू कैन कंटिन्यू प्लीज।
यस सर. तो डिलीवरी रूम, द प्रिकॉशंस जो लेना है डिलीवरी रूम में, रिसर्चेशन एरियाज कॉर्नर शुड बी 2 मीटर अवे फ्रॉम द डिलीवरी साइट. अपने आप को प्रिपेयर करना है फुल पीपी किट पहन के, गाउन विथ ग्लव्स, N95 मास्क और देयर इज वाज फेस शील्ड and triple layer mask, surgical mask for the mothers. So how will do in neonatal resuscitation? The NRP remains the same NRP protocol that we are following in day-to-day practice will be the same. There is a delayed cord clamping, skin to skin contact to be practiced, 2% technique during bag and mask ventilation, and T-piece resuscitation to avoid air leak. There is a predetermined path in a closed incubator for the transport of newborn. Suppose that baby needs admission in NICU, so there should be the predetermined path in a closed incubator for the transport of newborn. Yes, sir. Next. Now, where should newborn be placed after newborn? After born to COVID-19 positive or suspect mother. Hello. Hello, sir. Now, after resuscitation, where should newborn be placed after born to COVID-19 positive or suspect mother? We generally categorize mother with COVID suspect, stable neonates, or mother COVID positive stable neonates. If mother is sick, next sir, next slide.
ये स्पीकर से तो उनको आवाज
डॉक्टर साहब आप प्लीज बताइए, सो दैट प्लीज डोंट वेट फॉर स्लाइड.
Okay.
आई अंडरस्टैंड टेक्नोलॉजी का इशू, आप समझ सकते हैं.
Suppose that baby born हो गया, now we categorize the new.
सर बस एक मिनट में आपको इंटरप्ट करूंगा. ये प्रेजेंटेशन की स्लाइड सही है या किस प्रेजेंटेशन की किस स्लाइड पर जाना है, आप एक बार बता देंगे. ये क्लिनिकल इंपॉर्टेंस पर या आगे जाना है? नेक्स्ट स्लाइड ये सही है?
आगे जाना है सर. हाँ, आगे जाना है सर, इसके आगे. नेक्स्ट. हाँ, यहाँ से सर. यस
ठीक है डॉक्टर साहब कंटिन्यू करें.
Yes, sir. The neonatal resuscitation protocol will be the same like NRP that we are following in the day-to-day practice. In newborn, during intubation, there is a less chance of the spread of COVID-19 because the flow we are using, that is 5 liter, and tidal volume is so small, that is 6 ml per kg, 4 to 6 ml per kg we are using, and the dispersion is only 1 to 2 centimeter. and there is need for the intubation in COVID patient is less likely to be due to COVID, and it is more likely to be neonatal lung disease such as RDS, TTN, MAS, etc. And like in adults, the dispersion is 30 to 90 centimeter. That is high risk for healthcare worker near the airway. Next, sir. Next. Now, where should newborn be placed after born to COVID-19 positive or suspect mother? If mother is COVID suspect and the baby is stable, and mother COVID positive and stable neonates, if mother is sick, if answer is yes, then shift to well baby COVID ward and will give express breast milk. If not, if express breast milk is not available due to the sickness of the mother, we will use donor milk, donor pasteurized milk, or the formula. If mother doesn't sick, then room in with the mother in COVID postnatal ward and allow breastfeeding with the respiratory precautions. The next scenario is when mother is COVID suspect and neonate less than 34 weeks or sick. The baby should be shipped to the COVID suspect NICU or SNCU. The another scenario is if mother is COVID positive and neonate less than 34 weeks or sick, shift to COVID positive NICU or SNCU. So we have to make 4 wards, that is rooming in with a mother, and there is a well baby COVID ward and suspect COVID NICU or COVID positive NICU or SNCU. Next, sir. Next. Now the care of term and preterm infant born to COVID positive mother. Mother-infant separation only if baby or mother is sick. RT-PCR should be done at 24 and 48 hours after birth to rule out the vertical transmission. If expected to be discharged, asymptomatic neonate, single test at 24 hours is sufficient as per the CDC guideline. KMC and skin-to-skin contact, including breastfeeding, saves more lives than risk of transmission and disease to the neonate. These are WHO guideline. Next, sir. Now, organization of NICU. How you organize our NICU or SNCU? Now there is a donning areas. Donning areas, there is a strict hand hygiene. Sir, previous slide, sir. There is a donning area proper where you are area of hand hygiene. Now we scrub, and there is a gowning areas. After that, there's a entry in NICU, and in NICU, the ensure 100% hand hygiene compliance, and the distance between the 2 armors should be maintained at least 2 meter distance, and disinfection of stethoscope, BP cup, thermometer with 70% ethyl alcohol after each use. And there is a doffing proper area in which after doffing, the hand wash before leaving the room is mandatory. And there is a counseling room outside the NICU, and the distance between to maintain the 2 meter distance between the attendant and the counselor. Next, sir. क्या हुआ, चला गया क्या?
डॉक्टर साहब कंटिन्यू रहिए आप प्लीज.
नहीं वो सर ये Yes, sir. What are infection control measures mothers should take while caring for newborn? Hands should be washed for 20 seconds using soap in water or use sanitizer with at least 60% alcohol. Wear a mask within 60 feet of newborn. Keep newborn away after feeding at least 6 feet most of the time. Regularly disinfect frequently touch surface areas. No rule of washing breast with soap and water before breastfeeding if hand hygiene is followed. Next, sir. Next slide, sir. COVID-19 and breastfeeding. Breastfeeding, KMC, skin to skin contact benefit outweigh risk of COVID-19. If mother is polysymptomatic or asymptomatic, roaming in is feasible and direct breastfeeding is advisable under strict infection control. So next slide. If mother is too sick to take care of the baby, express unpasteurized fresh breast milk should be given. So next. In the above, roaming in with the direct breastfeeding, while there is a demonstration, and in the middle there is a roaming in where the roaming in is not possible, how to express breast milk and healthy care provider, nurse giving the EBM with a spoon. And another scenario, mother's own milk not available, then there is a pasteurized donor milk or formula milk can be given to the baby. Next slide, sir. Next slide, sir. Now the management. The management is mainly supportive in the newborn. Currently, evidence of antiviral and steroid in neonatal COVID is lacking. Favipiravir, hydroxychloroquine, lopinavir, ivermectin have no role. Steroids, if having rapidly downhill course with hypoxemia. Next slide, sir. Now, there is a possibility of MIS in newborn. When will you suspect MIS in newborn? There is a definition by the WHO. The definition is same for the newborn and the 0 to 19 years. If there is a fever for more than 3 days and 2 of the following, rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, feature of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities, including echo finding or elevation of troponin and BNP. Evidence of coagulopathy, there is an increased PT, APTT, elevated D dimers, acute gastrointestinal problem like diarrhea, vomiting, or abdominal pain. And among these, the clinical feature, 2 of the following with fever for more than 3 days and elevated CSR, C-reactive protein, or procalcitonin, and no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcal or streptococcal, and evidence of COVID positive 19 or likely contact with patients with COVID-19. These are the definition given by the WHO for the multi-inflammatory, multi-system inflammatory syndrome in newborn, and the definition is same. So if we diagnose this, then we have to manage accordingly. If there is a shock, we will manage the shock, and we will follow accordingly the management, which is discussed later on in the next presentation. Next slide, sir. There is a case which is published online ahead of the print in pediatric infectious disease. There is a 4-year-old term infant born to mother without history of COVID-19, developed PPHN, subsequently had multi-system involvement in the form of fever, bilateral ground glass opacities in chest X-ray, necrotizing enterocolitis-like illness, vasculitic rash, elevated inflammatory markers, and D dimer. Both the mother and infant tested positive for IgG antibody against SARS-CoV-2. Transplacental exposure to the maternal IgG could have contributed to the cytokine storm in the newborn. Treated with dexamethasone in addition to the management of PPHN, which leads to the complete recovery. It is published. It is yet to publish. This is online published. Next slide, sir. Immunization and family participation. The follow routine immunization policy in case of COVID positive newborn. One healthy family members following contact and droplet precautions should be allowed to stay with the mother to assist in baby care activities. Next slide, sir. What you should explain the parents before sending baby home. Count respiratory rate 2 to 3 times a day when not crying. Look for chest in drawing, nasal flare, bluish discoloration of the body, cold extremities, urine output, and whom to contact in case of emergency. If the breathing difficulty, poor feeding, altered sensorium, seizure, or there is a hypoxemia, if SpO2 level less than 94%, bring the baby immediately. Baby should not be handled by multiple persons, and the correct masking and hand hygiene by all the family. Next slide, sir. The key message of this presentation is neonate can acquire COVID-19 during delivery, but more commonly during postnatal period at home. That we can prevent by the simple measure like respiratory precautions by mothers and the proper hand washing. Majority of it is preventable. Majority of neonates do not develop symptoms or have mild illness due to COVID-19, and prognosis is good. Roaming in, breast milk feeding, KMC immunization, and routine care should continue. Communication with the family should be strengthened. Keys to protection: minimal handling, respiratory etiquettes, universal masking, hand hygiene, and physical distancing. Next. Thank you, sir.
Thank you so much, Top Saab. Thank you for your valuable presentation. We are sorry for brief interruption in between, but now we have a stable connection. So with the permission of Additional Chief Secretary, sir, I would like to invite the second speaker for the day, Dr. Preeta. Dr. Preeta, can you kindly confirm whether you'd be able to share your screen yourself or, yeah, okay, thank you, thank you.
Welcome, sir. I, Dr. Preeta Nazubraj, will be speaking on the management of COVID-19 in children aged 2 to 18 years. This one.
Good afternoon, ma'am. Your voice is audible. I just request you to kindly check if there are two systems which from which you have logged.
COVID-19 pandemic, also known as coronavirus pandemic, is ongoing global pandemic of coronavirus disease 2019 caused by severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2. The virus was first identified in the month of December 2019 in Wuhan, China. WHO declared public health emergency of international concern regarding COVID-19 on 30th of January 2020 and later declared a pandemic on 11th March 2020. As of 18th May 2021, more than 163 million cases have been confirmed, with more than 3.39 million deaths attributed to COVID-19, making it one of the deadliest pandemics in history. The mode of transmission in children are basically direct contact transmission, droplet transmission, and airborne transmission. How can we prevent these transmission? We can reduce droplet transmission by decreasing physical contact, cleaning the surfaces, wearing masks, maintaining social distancing. And how can we prevent airborne transmission? By ventilating. The room should be well ventilated, air filtration, prevention from going to crowded places, and wear masks even in the indoors. COVID-19 is caused by novel coronavirus SARS-CoV-2. Compared to adults, Children can also be affected with the virus that causes COVID-19 and can get sick from COVID and can spread the virus that causes COVID-19 to others. The incubation period of SARS-CoV-2 appears to be same as that of adults, 2 to 14 days, with average of 6 days. Most children are most children have mild symptoms or have no symptoms at all. However, some children can get severely ill from COVID-19 and they might require hospitalization, intensive care, ventilation, and in rare cases, death may also occur. Symptoms and severity of COVID-19 in children. Signs and symptoms of COVID-19 in children include unremitting fever, more than 38 degrees centigrade or 100.4 degrees Fahrenheit, fatigue, headache, myalgia, cough, rhinorrhea, nasal congestion, loss of taste or smell, sore throat, shortness of breath, respiratory distress, abdominal pain, diarrhea, nausea, vomiting, poor appetite or poor feeding. The most common symptom in children is fever and cough, but evidence suggests that as many as half of the pediatric infections may be asymptomatic. Signs and symptoms of COVID-19 in children are similar to those of other infections or non-infectious processes like influenza, streptococcal pharyngitis, allergic rhinitis. Lack of specific signs and symptoms and significant proportions of asymptomatic infections make symptom-based screening for identification of SARS-CoV-2 in children particularly challenging. Some children may present with atypical symptoms like GIT symptoms like abdominal pain, diarrhea, vomiting. Some may even present with cutaneous manifestations like urticaria, maculopapular rashes, vesicular eruptions. COVID toes, generally reddish or purplish nodules, is seen in distal digits, which are more common in children and young adults. How will we diagnose COVID-19? RT-PCR or TrueNAT. TrueNAT is generally preferred because it gives faster result than rapid antigen test, but it has low sensitivity. So if rapid antigen comes to be negative, then it should be confirmed with RT-PCR. And nowadays, CRISPR or mediated detection or loop mediated isothermal amplification are also being used for detection of COVID-19. A positive RT-PCR confirms the diagnosis of SARS-CoV-2. A single negative RT-PCR is sufficient to exclude the diagnosis. Like symptoms are suggestive or clinically we are getting this clinically and by investigation, then it should be repeated after 24 hours. Blood test. Majority of children are suspected to be asymptomatic or have mild to moderate symptoms. So no additional blood tests are required in these children. However, in severe cases, CBC, blood cultures, coagulation profile, D-dimer, renal function test, liver function test, CRP, ESR, ferritin, LDH, troponin, blood gases should be done. Radiology, chest X-ray and CT scan may reveal findings even in asymptomatic children. However, these should not be conducted routinely, even if children require oxygen on admission. Now we'll see how to manage children with COVID-19. Asymptomatic children are usually identified while screening. If family members are identified, such children do not require any treatment except monitoring for development of symptoms, and subsequently, according to symptoms, they are managed. Mild diseases, children with mild disease may present with sore throat, rhinorrhea, with no respiratory difficulty. Few children may have GIT symptoms, and these children do not need any other investigations. These children can be managed at home with home isolation and symptomatic treatment. For home isolation, it is important to assess whether home isolation is feasible or not. There should be isolation at the patient residence and also for quarantining the other family members. Their parents or other caretaker who can monitor and take care of the child. The parent or caregiver has agreed to monitor the health of the child and regularly inform about his or her status to the surveillance officer or director. However, if children have underlying comorbid condition, like if the child has congenital heart disease or chronic lung disease, chronic kidney disease, or any other organ dysfunction, obesity may also be managed at home if they have features of mild diseases and they have easy access to health facility in case of deterioration. However, if there is any lack of arrangement to manage these children at home, they should be admitted for observation. Treatment of mild illness. Home isolation should be done if there is fever. Paracetamol 10 to 15 mg per kg per dose may be repeated every 4 to 6 hourly. If there is cough, throat soothing agents like warm saline goggles in case of older children should be used. We should ensure that the child maintains hydration and eats a nutritious diet. Antibiotics not indicated. There is no role of hydroxy, chloroquinone, favipiravir, ritonavir, remdesivir, immunomodulators, plasma infusion, or dexamethasone. What monitoring should be done at home? We should explain the parents or caretaker to maintain a monitoring chart, and they should count the respiratory rate at least 2 to 3 times a day when the child is not crying. They should look for chest indrawing, any bluish discoloration of the body, urine output, cold extremities, oxygen saturation monitoring by handheld pulse oximeter if feasible, fluid intake activity, especially for young children. And there should be regular communication to doctor or healthcare worker. Parents should be explained whom to contact in case of emergency. Now, management of children with moderate COVID-19 disease. Children with COVID-19 will be categorized as having moderate illness if he or she has tachypnea, that is rapid respiration as per age. If less than 2 months, if respiratory rate is more than or equal to 60 per minute, 2 to 12 months, if respiratory rate is more than or equal to 50 per minute, 1 to 5 years, respiratory rate is more than or equal to 40 per minute, and more than 5 years, if respiratory rate is more than or equal to 30 per minute. And oxygenation saturation is above 90. Children with moderate COVID-19 disease may be suffering from pneumonia, which may not be clinically apparent. Now, how to manage? They should be admitted in dedicated COVID health center or secondary level healthcare facility and monitored for clinical progress. Fluid and electrolyte balance should be maintained. Encourage oral feeds. If the baby is breastfeeding, then breastfeeding should be continued. If oral intake is poor, then IV fluid should be given. For fever, paracetamol 10 to 15 mg per kg per dose may be repeated every 4 to 6 hourly. If amoxicillin can be administered if there is strong suspicion of infection. If SpO2 is below 94%, then oxygen supplementation is required. Corticosteroids may be administered in rapidly progressing disease, but it is not required in all children with moderate illness, especially within first few days of the illness, and supportive care if any comorbid condition exists. How to monitor of moderate cases? Clinically, we should monitor heart rate, respiratory rate, blood pressure, SpO2. We should look for work of breathing is normal or there is increased work of breathing. Laboratory, if there is deterioration or hypoxia, CBC, platelet count, absolute lymphocyte count, RFT, LFT, CRP, D-dimer, and ferritin. Management of children with severe COVID-19 diseases. Children with SpO2 level less than 90% are categorized as having severe degree of COVID-19. Such children may be having severe pneumonia, acute respiratory distress syndrome, septic shock, multi-organ dysfunction syndrome, cyanosis, increased respiratory efforts like grunting, severe retractions, lethargy, seizure, somnolence. Such children should be admitted in dedicated COVID hospital, secondary, tertiary health facility. We should assess for thrombosis, hemophagocytic lymphohistiocytosis, organ failure. Investigation should be CBC, liver function test, renal function test, chest X-rays. Treatment is IV fluid should be given. Corticosteroid dexamethasone 0.15 mg per kg per dose, maximum of 6 mg twice a day is prescribed for 5 to 14 days. Equivalent dose of methylprednisolone can be given. Antiviral agents like remdesivir is used. However, there is lack of sufficient safety and efficacy in children below 19 years. However, emergency use has been granted. The suggested dose is if more than 40 kg, then 200 mg on first day, then 100 mg once daily for 4 days. And if body weight is 3.5 to 40 kg, then first day we give 5 mg per kg and subsequently 2.5 mg per kg once daily for 4 days. However, there is no role of hydroxychloroquine, favipiravir, ivermectin, lopinavir, ritonavir. And in case there's organ dysfunction, then they may need organ support. If management of ARDS, the principles of treatment are same to that of ARDS. Agar mild ARDS hai, then high flow nasal oxygenation, NIV. Severe hai, mechanical ventilation may be given with low tidal volume. These will be discussed in the later section. If the child develops shock, then crystalloid bolus administration 10 to 20 ml per kg or 30 to 60 minutes can be given. If there is any cardiac dysfunction, then we should be cautious in using. Early inotrope support should be given with monitoring of fluid overload. This is a flow chart which shows the management of child with COVID-19. If there is mild illness like sore throat, rhinorrhea, cough, no fast breathing, home isolation should be done, supportive care, rest, adequate hydration and feeding. If there is fever, paracetamol 10 to 15 mg per kg per dose, and the monitoring should be done and report if there is worsening of symptoms. Evaluate all admitted children with CBC, LFT, RFT, coagulogram, CRP, D-dimer, fibrinogen, chest X-ray, blood culture. If home monitoring not possible, admit the children with mild illness who are having comorbidities like chronic lung disease, CKD, heart diseases, or any neurological diseases. Nebulization should be avoided. If they are required, then use MDI. In moderate illness, if there is tachypnea, but there's no signs of severe pneumonia illness, then admit the child, monitor for progress. Fluid or feet they should maintain hydration. If there is fever, then give paracetamol. If there's suspicion of bacterial infection, then amoxicillin can be given. If SpO2 is less than 94%, then start oxygenation. If there's rapid progression, deterioration, then steroids can be added. If there is severe pneumonia like ARDS, sepsis, septic shock, multiple organ dysfunction syndrome, pneumonia with cyanosis, SpO2 less than 90%, increased respiratory effort, lethargy, somnolence, and seizure, admit preferably in ICU or HDU. Evaluate for thrombosis, hemophagocytic lymphohistiocytosis, organ failure, start steroids, remdesivir, empirical antimicrobials, oxygen therapy, and consider awake prone positioning, restrict the fluid therapy, and organ support should be given. ARDS, mild ARDS, high flow nasal oxygen, NIV should be given. If ARDS, then mechanical ventilation with low tidal volume, high peak, fluid restriction should be done, sedation, and if poor response, may try prone ventilation. If shock is there, crystalloids bolus can be given 10 to 20 ml per kg over 30 to 60 minutes. If then it can be given fast. However, if there is myocardial dysfunction, then we should be cautious in giving bolus. And inotrope should be and monitor for fluid overload. Steroids, dexamethasone 0.15 mg per kg per dose twice a day for 5 to 14 days is preferred. Equivalent dose of methylprednisolone or prednisolone may be used. Remdesivir, no trial data in children. However, it can be used if in cases more than 40 kg, 200 mg on day one, once daily for 5 days, and 3.5 to 40 kg, 5 mg on day one, and then 2.5 mg per kg once daily for total duration of 5 days. Only masking properly and washing our hands can save us. Thank you.
Thank you so much, ma'am. Thank you for your presentation. This was very important for all the participants because we expect that most of the target group, in case of any further outbreak, would be in the age group which has been already covered by you. Now, with the permission of Additional Chief Secretary, sir, I would like to request Dr. Saktipad Das for a brief presentation on use of ventilators in severe COVID-19 newborn and pediatric cases. As this is an area with respect to which we would be requiring more and more support. And this is a kind of unventured terrain for all of us as of now. Over to you, Dr. Das, please.
Good afternoon, everybody. My audio is audible?
Audible, and the screen is also visible. You can make the presentation a full slide, so rest all is okay. Thank you.
Yeah. Good afternoon, everybody. Myself, Dr. Saktipad Das. I'm currently doing work in Rani Hospital, Ranchi. My topic is use of ventilators in severe COVID-19, newborn and pediatric cases. Coming on to the first slide, what is the definition of severe disease in pediatric and newborn case? There may be two clinical scenarios. First is children may present with a pneumonia with any of these following situations, like saturation less than 90%, increased respiratory effort, grunting, severe retraction, lethargy, seizures, somnolence, severe diarrhea, vomiting, and abdominal pain. Or the pediatric patient may present in a critical stage, which is a subset of severe disease, which is defined as if he is in ARDS, that is acute respiratory distress syndrome, or in shock, having multiple organ dysfunction, or in acute thrombosis. Management includes first, the patient should be admitted in COVID-19 ICU, HDU, or dedicated ward. Primary investigation should be sent like CBC, RFT, LFT, CRP, PCT, D-dimer, ABG, lactate, ECG, or chest X-ray. If the situations needed, we can send PROC-T, ECHO, ferritin, or LDH. The treatment option includes steroids plus minus remdesivir if the clinical conditions wants, empirical antimicrobials, oxygen therapy via nasal prong, face mask, or HFNC, NIV mode, mechanical ventilation, restrictive fluid therapy, or organ support in form of renal replacement therapy. So there may be two clinical scenario in a patient who present in severe form of disease. First is acute respiratory distress syndrome. Second scenario is shock. In acute respiratory distress syndrome, there may be the patient may be in mild ARDS. The treatment portion includes HFNO or an IV trial. In severe ARDS, we should ventilate the patient with low tidal volume, that is 6 ml per kg, high PIP, cuffed endotracheal intubation should be there. There should be a fluid restriction, having adequate sedation. If poor response, we may try prone position ventilation, or other options include HFOV, that is high frequency oscillator ventilation, or ECMO. In other clinical scenario, the patient may present in shock. It may in the form of septic shock or myocardial dysfunction. The treatment will include crystalloid bolus at a rate of 10 to 20 ml per kg over 30 to 60 minutes. Fast if patient is in hypotensive. There should be careful administration of fluid because it may deteriorate the condition if patient is in having myocardial dysfunction. There should be hello. My voice is audible, no?
Yes, Dr. Saab, it's audible.
There should be early start of inotropic support, and monitoring for fluid overload should be carefully done. Now coming on to the therapy in these severe cases of patient, first is oxygen therapy. We should give supplemental oxygen therapy to target SpO2 around 94 or greater than 94% during resuscitation and greater than 90% for stable or recovering child. Nasal prong or cannula are preferred in children as it may be better tolerated, or surgical mask or hood cover to decrease the risk of aerosolization and droplet spread should be there. If the child is on oxygen through prongs and SpO2 is less than 90% with minimal respiratory support, then the options should be first is face mask at a flow greater than 5 liters per minute. These face masks at these rate, they maintain a FiO2 around 40 to 60%. Oxygen hood at a flow greater than 5 liters per minute, they maintain a FiO2 around 30 to 90%. Venturi mask, 28 to 60% FiO2. Non-rebreathing mask at a flow rate of 10 to 15 liters per minute, they maintain a FiO2 around 80 to 90%. Now, coming on to the respiratory support, if the patient needs respiratory support, they may be given in form of high flow nasal cannula, that is HFNC, or non-invasive ventilation via mask, that is NIV. So coming on to HFNC, these HFNC, they titrate the flow at a rate 0.05 to 2 liter per kg. We delivered the flow rate at 0.5 to 2 liter per kg to maintain the FiO2 at 60%, to maintain saturation greater than 92%. Apply surgical mask over the FNNC. Use minimal flow that makes the baby comfortable. Target SpO2 should be 90 to 94%. During HFNC administration, we should monitor the heart rate, respiratory rate, saturation, and work of breathing of the child. Wait for 1 to 2 hours for response after any interventions. HFNC failure may be defined as worsening of Rock's criteria that is less than 4.88. It is defined as SpO2 divided by respiratory rate into FiO2. Now coming on to NIV, NIV delivers via two limb standard ventilator. The CPAP helmet is preferred over oronasal mask. Bacterial or viral filter, that is HME filter, should be connected to expiratory limb. We should start with PEEP around 5 centimeter of water. Higher PEEP can lead to leak or aerosolization. So we should avoid it if possible, if the scenario permit us. Pressure support should be added if CO2 elevated. Titration of pressure support to achieve the saturation or a FiO2, that is SF ratio, should be greater than 265 or pH 7.35. Now responder, who the patient who respond to HFNC or NIV, their respiratory distress should improve. Heart rate and respiratory rate decreases by 20%. FiO2 requirement decreases by less than 50%. If these things happen in the patient having HFNC or NIV mode, then we should continue the therapy, but we should monitor for worsening or secondary infections. Suppose the patient does not respond with this mode of respiratory support, then we should go for mechanical ventilation. So coming on to mechanical ventilation, first indication for the intubation. First is if the child is having persistent or worsening respiratory distress, having SpO2 less than 88 to 90% and HFNC or NIV with a FiO2 greater than 60% requirement. Contraindication to non-invasive ventilation like hemodynamic instability or altered mental status. Progressive hypercapnia, that is rising PCO2 if pH is less than 7.35. Drowsiness or fatigue. Patient develop refractory shock with need for high dosage of pressure support, or they develop cardiac dysfunction or they develop lactic acidosis, then there is a need for mechanical ventilation in these types of issues. Or other sets of person, if they having multiple organ failure, CNS issues like encephalopathy, seizures with inability to maintain airway, or having hypoventilation, or much lower threshold in patient of high risk children, then these conditions also demand mechanical ventilation. High risk children are generally age less than 1 year, having comorbidities like immunocompromised patient, chronic lung, renal or liver diseases, having diabetes or some cardiac ailments, then they should have a low threshold for mechanical ventilation. Now, how we prepare in a COVID-19 intubation, because it is a high risk procedure, both for the patient and for the healthcare worker. So first of all, the preparedness, if available, video laryngoscopy is preferred, and the person who is doing intubation, he should be he should having expertise in intubation. First pass intubation is ideal. Choice of drug for sedation during intubation is ketamine at a dose of 0.5 mg to 1 mg per kg, or rocuronium at a dose of 0.6 mg per kg. Apneic oxygenation if possible. Use nasal prong or face mask less than 5 liters per minute for 5 minutes. Maintain saturation greater than 92% during intubation. Do's or don'ts during intubation. Use rapid sequence intubation. Give full dose of sedation and full dose paralysis to avoid cough. because they sprayed more aerosol. Wait for 30 to 60 seconds for complete knockdown before intubation. Avoid performing big mask ventilation, that is BMV ventilation. If BMV is essential, we should use bacterial or viral filter or HME filter to ensure two-handed tight mask seal with with small tidal volumes. We should not insert NG tube before intubations. Do not do the oral suction unless absolutely essential, or should perform after giving muscle relaxation. We should use only cuffed ET tube. ET tube distance to be prefixed or predetermined prior to injection. After intubation, we should immediately clamp the end of ET tube near adapter. Immediately post intubation, the pre-prepare connection should be connected, that is inline suction if available, EtCO2, HEPA filter or ventilatory circuit. We should release the clamp which we applied at the end of adapter. Do not bag to check for bilateral equal entry. Fix the ET tube securely. If previous test is negative, then we should send the lower respiratory secretion for COVID PCR test again. During ventilation, we should maintain a closed suction or HME filter should be applied. Avoid circuit disconnection. Inhaled medicine should be given via MDI. Follow standard periodic WAP bundle precautions. So what should be the ventilator strategies in these types of patients, as these are generally having ARDS or in modes. So we should use the lung protective strategy. Whenever possible, FiO2 should be maintained at around 60%, with tidal volume should be lower tidal volume, that is around 5 to 7 ml per kg ideal body weight. Lower tidal volume with poor lung compliance is essential. Keep up to 10 centimeter of water in severe disease. It may to titrate the SpO2 around greater than 88%. We should not rush for the saturation to increase beyond 88%. If the saturations maintaining around greater than 88%, then we should continue with the ventilation. Consider dead space effect for persistent poor compliance or hypoxemia and elevated air pressure. They may need to decrease the PEEP and minimize the airway pressure. Target saturation should be around greater than 88%. pH should be greater than 7.15. If the patient is having RV dysfunction or pulmonary hypertension, aim of pH should be 7.3. We should limit the driving pressure less than 15 centimeter of water or plateau pressure less than 30 centimeter of water. Early and deep sedation with neuromuscular paralysis for initial 48 hours is essential. Hemoglobin target should be around 7 gram if the patient is stable. We should maintain the negative fluid balance, avoid fluid boluses unless clear evidence of fluid loss is there. Consider early vasoactive or inotropes to maintain the perfusion or desired MAP, that is mean airway pressure. Early proning with close monitoring is essential if the conditions demand or if the condition of the patient deteriorates. If the patient is having persistent hypoxia in spite of if the patient is having persistent hypoxia in spite having mechanical ventilation support, then we should repeat the chest X-ray or consider secondary infections. We should send the tracheal secretion for gram stain or culture. Consider empirical antibiotics. Usual criteria should be followed co-infections should be looked for. We should consider for chest tube if feasible. The condition of the patient if allowed, we should go for chest X-ray. PEEP titration should be done to maintain the saturation. Careful recruitment maneuver if lung is recruitable should be done. Frequent echo for RB or LV function should be done. Target hemoglobin should My audio is visible?
Yes, yes, your audio is audible. Please go ahead.
Audible, na?
Yeah, audible. Please go ahead.
Frequent echo for right ventricular or left ventricular function should be done. Target hemoglobin should be around 10 gram per deciliter in these types of patient. Trial of inhaled nitric oxide should be initiated early if there is suspicion of pulmonary hypertension or RB dysfunction is present. Consider for trial of high frequency oscillatory ventilation. Steroid role of steroid is controversial. If patient is not on dexamethasone, we may consider for methylprednisolone 1 to 2 mg per kg per day in divided doses. Refractory hypoxemia, despite all these above measures present, then we should consider for ECMO if available. If the patient is improving in ventilated patient, if the signs is showing some improvement, then when we should consider extubation, there is a required guidelines for this. We should consider pre-extubation. The patient should be given pre-extubation dexamethasone if the risk factor for post-extubation stridor is present. SBT trial should be given. Use only PEEP without pressure support. Avoid TPs. Extubation criteria similar to any ARDS patient should be given. Extubation should be to the face mask, not to NIV or HFNC because of aerosolization risk. Aerosol precaution should be required. Two staff member with full PPE to perform the extubation. The patient should not be encouraged to cough. Prior to endotracheal tube removal, gentle or oral suctioning may be performed with care so as not to precipitate the coughing. Supportive care in a case of ventilated patient. We should ensure the invasive lines like femoral central line, like femoral route is preferable. Arterial line for blood gas and blood sampling, urinary catheter or nasal tube. Sedation or analgesia infusion should be started if the patient demands or if the conditions demand. Use unit specific regimen should be used. Fluid and renal support should be maintained. We should keep orally dry. Monitor renal function renal function. We should monitor the renal function, treat shock or hypoperfusion. Establish acute renal failure in case of patient who develop acute renal failure. We should fluid management and renal replacement therapy according to protocol should be instituted. If the patient showing coagulation, a deranged coagulation, then we should consider for low molecular weight heparin. If the patient showing GI issues, we should watch for gut ischemia like bloody stool, severe abdominal pain. The issue should be taken care of. Nutritional targeted in a ventilation patient, calories should be around 55 to 60 calorie per kg per day. And protein should be given 1 to 1.5 gram per kg. TPN should be considered after 3 to 5 days if target are not made. Prevention and treatment of healthcare associated infections. Family counseling. As such, we should remember family members are likely to be carrier or infected. So we should use appropriate precautions while doing family counseling. We should treat these patients. Conservative food strategies should be there. We should avoid colloids. In case of shock or hypoperfusion, including septic shock, vasoactive amines should be vasoactive drugs should be instituted early, like epinephrine in case of septic shock, or inodilators like milrinone, or diuretics in case of myocarditis. We should maintain age-appropriate mean arterial pressure. So judicious use of norepinephrine should be warranted. Thanks.
Thank you, Dr. Saab. Thank you very much for your nice presentation. Though it was technical, but you had made all efforts to make it understandable for laymen like us. So thank you very much. And I'm hopeful that other pediatricians and other doctors who have been listening would be getting in touch with you with respect to further details. And we will be having opportunity to take your services for more trainings in the time to come. Thank you again. So, with the permission of ACS, sir, now I would like to request Dr. Rajesh Kumar and Dr. Apeksha Pathak for their presentation on other clinical presentations among COVID-19 positive, especially for the newborn and the pediatric age group. Dr. Rajesh, please.
Am I audible and visible as well?
Yes, yes, Dr. Saab, both the presentation is visible and your voice is also clear.
Okay. Next, in this session, myself and Apeksha will be dealing with the other clinical presentation. Apeksha will be dealing the pediatric part. Mostly, she will be dealing with the MIS, that is multi-system inflammatory syndrome. And to inform everybody, this is a real problem for us. We have admitted at Rani Hospital almost 12 cases in last 7 days. Currently, 10 children are admitted with multi-system inflammatory syndrome, and out of them, 7 are in ICU. And basically, it affects the heart mainly, so it requires ICU care. So that also aspect should be looked into. That is very important, and it happens almost 1 month after the peak of Corona, because it's a post-COVID. So 1 month after the peak of Corona, your MIS in children will happen. I'll be dealing with the neonatal aspect, and I'll be dealing with 4 cases. For case 1 is this neonate was a term baby, 3 kg at birth, and born to mother with COVID-19. And on day 4, baby had convulsion, low blood sugar, and he was in encephalopathy. He was unconscious. And we didn't know what is happening, but there was a history. Since there was a history of COVID-19, we did RT-PCR. RT-PCR was positive, and this baby recovered with the supportive care in next 10 days. Second case, this baby had come on day 14 of life. Again, term baby, 3.2 kg at birth. X-ray was suggestive of pneumonia, and your blood culture was sterile. Other parameters were also normal. So we thought it may be a case of COVID. So we did RT-PCR, and RT-PCR came positive. And also it had the effect on the heart also, mild tricuspid and mitral regurgitation. And this case was a case of pneumonia with pulmonary hypertension. This baby has also recovered. And this baby with gastrointestinal symptom, this baby was born with the mother who was on ventilator, and the mother was very critical. So they decided to take out the baby. At least baby can be saved. They were twins baby. One baby we have already discharged. This is a second baby. This is a low birth weight, 1.6 kg. RT-PCR was negative at 48 hours. Baby was all right till day 8 of life. Day 8, baby started having distension of the abdomen, and bacterial investigation we did was normal. RT-PCR we did on day 10, well, it came positive. Baby had necrotizing enterocolitis, which is very bad disease for abdomen. underwent operation also. Currently, baby is on ventilator. Here, I want to highlight the newborn. You can have RT-PCR positive till day 14 of life. So ideally, if you want to 100% detect the cases of mother to baby transmission, you can do RT-PCR at first day, on day 5 to 7, and again between day 12 to day 14. If you want to exclude 100% that the baby has not got the infection from the mother. This baby admitted yesterday night, evening, and this baby came with loose stool and fever. Loose stool, fever, abdominal distension, edema, and redness of the eye. And 9 months old, 9 kg. Has total count high, platelet was very high. And X-ray showed cardiomegaly. And we did antibody for COVID. It was positive. And we did echo also. Echo showed pericardial effusion. So this is the multisystem inflammatory syndrome in an infant. And this baby is also currently admitted in pediatric ICU. So I just presented 4 cases because we think that is only present with the pulmonary symptom. It's not like that. It can present with the GI tract in children, especially small children with diarrhea and vomiting, especially infant. It can present with the renal failure. Many of our cases have renal failure. Hepatitis is also common. One patient is admitted with the hepatitis with us. Heart, it can affect the heart. It can affect the brain also. Why neonates are important? Because smaller the baby, like infant less than 1 year, at high risk of admission. And the babies who are less than 1 month of age, they have a 3 to 5-fold higher risk of getting admitted into ICU. So the care of smaller babies are very important, and they have a high tendency to get admitted. Main symptoms, although they present with respiratory distress, fever, and feeding intolerance. They are not feeding well, because many of the patients we admitted in this COVID, we have admitted almost more than 50 patients during this COVID second phase. And many infants got admitted only because they were not eating properly. That's all. At what age the neonates present? They can present from the first week to day 30 of life. But mostly neonates, they present in the first 12 to 15 days of life. This is from the data from the last, from the UK, the last peak when they had. What are the main symptoms in the neonates? Fever. Fever is the most important symptom in the neonate. Then poor feeding and vomiting. Then you have coryza, respiratory distress, then tachypnea and cough. They are not so common as compared to the fever and feeding difficulties. Neonatal transmission already, Kiran has already told you. I'm not going to detail in this.
नहीं जाने का तो कर देगा ही नहीं, तो वहीं रहना है. ठीक है, वहां रहना है. फिर भी मान लीजिए कोई 11 बजे खाना खाने का टाइम है, 3 बजे खाना खाने का टाइम है.
डॉक्टर राजेश, आप अपना ऑन कर लीजिए प्लीज, ऑडियो ऑन कर लीजिए.
Okay, am I audible?
Yes.
Okay.
Now you are audible, please.
So mother to baby transmission occurs only approximately 2% of the infant, and but as I told you earlier, it can present till day 14 of life. There are 3 presentations in neonate, 3 types of presentation of neonatal COVID: early onset COVID, late onset COVID, and multi-system inflammatory syndrome as in children, but they can present in neonates also, but they are rare. Early onset COVID, mostly they are asymptomatic. They are detected on routine testing since mother was positive. And what are the symptoms of early onset? They present within first week of life. Temperature instability, may have hyperthermia or hypothermia also. They have poor feeding. They can have nasal congestion and flaring. They can have cyanosis, lethargy, diarrhea, and breathing difficulties. Another presentation in late onset COVID. these babies get discharged from the hospital, then they come back again, and either they will be a continuation of the baby infection which they acquired during delivery, or later on they acquire from mother or relatives. So they have again hyperthermia, fever, or they can have hypothermia, lethargic, respiratory difficulty, poor feeding. They can have low saturations. On X-ray, many of them will have pneumonia. What is MIS? MIS is basically antibody mediated. You see, no, this is antibody mediated, and if it is presenting in neonatal period, that means mother was having COVID. So mother was having COVID, say 1 to 2 months back or at around delivery. Then the antibodies, they pass on to the baby, and these antibodies, they causes reaction in the body. That is inflammation. And the main problem in this is affection of the heart. So myocarditis, you can have increase in troponin, you can have a coronary aneurysm on ultrasound. They can have involvement of the kidneys, they can have involvement of the GI tract, they can have involvement of the lung. The important thing is the treatment is different in MIS. Treatment is intravenous immunoglobulin. This is different from COVID. In COVID, we have mainly supportive treatment or steroid. Here, main treatment is intravenous immunoglobulin. Thank you. Thank you. Apeksha will continue.
Thank you, sir. Thank you, sir. A very good afternoon to all of you. I hope I'm audible.
Yes, ma'am, you are audible, and the presentation is also visible.
Thank you so much. Now, at the very outset, I would like to thank our chairperson and a co-chairperson for giving this opportunity to share my insights. Most of the relevant topics were covered by Dr. Rajesh sir, Dr. Kiran Das, Dr. Shaktipat Das, and Dr. Preeta Dubraj. It was an enriching experience to hear them. In view of impending fear of the third wave of pandemic, which is expected to affect mostly children, I will speak briefly about the few additional concern issues. I'm Dr. Apeksha, and I'm working in the Department of Pediatrics in RIMS. I'll be talking about the management of COVID-19 in pediatric age group. Mainly, I'll be dealing with MISI, multi-system inflammatory syndrome in children, is pathogenesis, clinical feature, diagnosis, and treatment, psychosocial impact of COVID-19 in children. Now, why are children less frequently or severely affected? Children less susceptible to infection by coronavirus in general, be it SARS-CoV-1, MERS-CoV, or SARS-CoV-2 as compared to other respiratory viruses. Most of the infections are spread from infected adult family members. Isolation of individuals with SARS-CoV-2 infection may reduce exposure to children. Among studies of household contacts, odds of infections in children were significantly less. Expression of primary target receptors of SARS-CoV-2, angiotensin converting enzyme 2, varies with age. ACE has lung protective effects by limiting angiotensin 2 mediated pulmonary capillary leak and inflammation. Children have strong innate immune response due to trained immunity secondary to live vaccines and viral infections. Early control of infection at the site of entry. Adult patients show suppressive adaptive immunity and dysfunctional overactive innate immune response in severe infections, which is not seen in children. Excellent regeneration capacity of pediatric alveolar epithelium may be contributing to early recovery from COVID-19. Children less frequently have risk factors such as comorbidities, smoking, and diabetes. Now, coming to my main topic, that is multisystem inflammatory syndrome temporarily related to SARS-CoV-2 in children, what is commonly known as MIS-C. First reported in UK in April 2021. The surge followed in COVID-19 by a month. Overall is uncommon, less than 1% of all the COVID-19 in children and adolescents, and less than 10% of children hospitalized with COVID-19 or related conditions. Now, looking at the WHO criteria of MIS-C, children and adolescents in the age group of 0 to 19 years of age with fever more than or equal to 3 days, and 2 of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs, oral, hands or feet, hypotension or shock, features of myocardial dysfunction, pericarditis, valvulitis or coronary abnormalities, including echo findings or elevated troponin or NT-proBNP. Evidence of coagulopathy by PT, PTT or elevated D-dimers, acute GI problems like diarrhea, vomiting or abdominal pain, and elevated markers of inflammation such as ESR, CRP or procalcitonin, and no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcal or streptococcal shock syndromes, and evidence of COVID-19 in the form of RT-PCR, antigen test or serology positive, or likely contact with patients with COVID-19. Now, looking at the pathophysiology of MIS-C, it is incompletely understood, but possible mechanisms could be due to immune dysregulation, antibody enhancement, T-cell mediated damage or enhancement of inflammation. Now, looking at the pathophysiology from this graph, we're looking at the mild disease and the severe diseases, including MIS-C. In case of mild disease, there's an early interferon response, which leads to rapid viral clearance and less inflammation. Whereas in case of severe disease, including MIS-C, there's a delayed interferon response, slow viral clearance, and more inflammation. We can see a higher blood level rise of cytokines like IL-6, which can lead to something called cytokine storm. Now, understanding the clinical spectrum, we categorize the patients into 3 types. First is classic Kawasaki disease or incomplete Kawasaki disease with or without shock. Second is hyperinflammation with myocarditis with or without shock, presenting with fulminant heart failure or subacute heart failure. And third is hyperinflammation without myocarditis, shock, and multi-organ failure. We have 3 classes of patients. Class 1, including 35% of the patients, they have hyperinflammation with MODS involving more than 6 organs, including cytokine storm. GI and cardiovascular systems are most commonly involved, and mortality here is around 0.5%. Now, class 2 patients comprise about 30% of them. There's respiratory symptoms, including ARDS, subacute heart failure, and carditis. Only 84% of them could be RT-PCR positive. Class 3, comprising of the rest 35% of the patients, it includes children around the age group of 6 years, along with Kawasaki disease with typical or atypical of them. There's no mortality in this category of patients, and only 63% are serology positive, and 34% both serology and RT-PCR positive. Now, evaluation of MIS-C. We basically look at the main 3 things, that is unremitting fever more than 38 degrees Celsius, epidemiological link to SARS-CoV-2, and third is clinical features suggestive of MIS-C. If answer of any of these 3 is yes, there's no other alternate etiology, and shock or life-threatening manifestations are present. If they are present, we simultaneously go for tier 1 test, or if they're not present, then we evaluate, we simultaneously go for both tier 1 and tier 2 test. And if they're not present, then we evaluate only for tier 1 test. And if there's a positive screen in tier 1 evaluation, only then do we proceed further to tier 2 evaluation. Otherwise, we consider the screen as negative, and we evaluate for alternate diagnosis and monitor for the features of MIS-C. And the answer of any of these 3 points that we have taken into consideration in the beginning, like unremitting fever more than 38 degrees, epidemiological link to SARS-CoV-2, and clinical features of MIS-C, if the answer of any of these 3 is no, then evaluate for alternate diagnosis and monitor for features of MIS-C. Now, tier 1 screening evaluation includes positive screen. Both of these should be present. CRP more than 5, and ESR should be more than 40, and or ESR should be more than 40. And at least one of the following, Absolute lymphocyte count should be less than 1,000. Platelets should be less than 1,50,000. Sodium less than 135. There should be neutrophilia and hypoalbuminemia. And tier 2 includes cardiac inflammatory markers and blood smear evaluation. Cardiac evaluation including ECG, echocardiogram, BNP, and TROP-D. Inflammatory markers including procalcitonin, PT, PTT, D-dimer, fibrinogen, LDH, triglycerides, and cytokine panel. And third is a blood smear. Now looking at the treatment of MIS-C with shock or life-threatening disease, and MIS-C which is not immediately life-threatening. The MIS-C with shock and life-threatening disease, we give them steroids and IVIG and antimicrobials. Steroids in the dose of methylprednisolone in the dose of 1 to 2 mg per kg per day, and along with IVIG 2 gram per kg over 24 to 48 hours, along with antimicrobials. But simultaneously, we have to evaluate for tropical infections. Now, looking at MIS-C, which is not immediately life-threatening, rule out the tropical infection first. If that is ruled out, then we start with steroid, again, methylprednisolone, 1 to 2 mg per kg per day, first line, or IVIG alternative of first line, either as per availability. Now, we also give antiplatelets and anticoagulation depending on the PT, APTT, and D-dimer profile. We give aspirin at a dose of 3 to 5 mg per kg per day, maximum going up to 81 mg per day. Indications is thrombocytosis and coronary aneurysm where Z-score is more than 2.5. Or else we give an enoxaparin. Indication for enoxaparin is coronary aneurysm, Z-score is more than 10. Thrombosis and LVEF, left ventricular ejection fraction, should be less than 35%. Not responding to initial immunomodulation, we can repeat a dose of IVIG, or else we can give high dose steroid, also called as the pulse therapy of steroid of methylprednisolone, in the dose of 10 to 30 mg per kg per day for 3 to 5 days. Now coming to the psychosocial impact of COVID-19 in children. Quarantine children away from family and siblings, post-traumatic stress disorder. Those who have lost their parents to disease suffer from grief, loneliness, and adversity. Children exposed to social media and gruesome pictures of disease and death. Fear, anxiety, clinginess, inattention, and irritability are some of the problems that they are facing in children. Negative outcomes later in life. During adverse childhood events, body's natural stress response may become dysregulated. Persistent elevation of cortisol and pro-inflammatory cytokines. All this can lead to delay in their cognitive development, somatic complaints, obesity, asthma, diabetes, sleep disturbances, premature death, closure of schools, academic loss, lack of physical exercise and outdoor activities, internet and cell phone addictions. This is an observational study based on 139 pediatric patients aged 1 to 17 years and confirmed COVID-19 positive, admitted in New Trauma Center Corona Isolation Ward in RIMS, Ranchi from the period of 1st April 2020 to 31st December 2020. The total number of cases under consideration were 139. Out of these, 67.6% were asymptomatic and 32.4% were symptomatic. Among the symptomatic, 1 to 5 years of age children belong to a group of 12%, whereas 18% belong to the group of 6 to 10 years, 52% belong to 11 to 15 years, and 18% belong to more than 15 years. Among these, fever and cough were the predominant symptoms, followed by breathing difficulty. Sore throat, diarrhea, and vomiting were less common, and rest of the other symptoms belong to the rest 60% of the cases. So to summarize in all, with the surge, more children are being affected. However, the profile of illness does not seem to have changed. The confirmatory tests are RT-PCR, CBNAT, RAT on a respiratory tract specimen. The classification of disease severity is predominantly based on clinical status. Management is predominantly supportive. Children can be managed at home if asymptomatic or mildly symptomatic. Moderate and severe illness are managed in inpatient facility. Rational use of medications are required. MIS-C is a condition related to COVID-19 being seen in children. However, it is uncommon. MIS-C, it is important to consider and rule out common differentials. Trials of vaccine in children are underway. Guidance likely to be based on documentation of safety and efficacy, adequate availability of vaccines. Thank you.
So thank you so much, ma'am, for your presentation, and thank you, Dr. Rajesh, for your detailed presentation. Definitely a guide for all the participants, and Now, I think we can open the webinar, the meeting for other participants also, so that anyone who intends to ask any question or any specific doubts are there, they may be addressed by the expert panel. So I will request that now everyone can be unmuted so that anyone who wants to ask any specific question can raise their hand or unmute their mic and then ask the question. Any questions, please?
Hello. Hello.
Yes, yes.
Please go ahead. Please ask your.
Am I audible? Am I audible, sir?
Yes, you are audible. Please go ahead.
Thanks for other mic. Okay. Am I audible?
Yes, you are audible. Please go ahead.
Yes. Yes. Sir, regarding the availability of resources in our state, can we have monitoring for every child with higher levels of markers like D-dimer, like heritage for every child? Maybe not have a plan that we should do CBC and CRP routinely to begin with, and later if found moderate to severe disease, then we'll follow the protocol as per recommendation of WHO, whatever it is. Simpler.
Dr. Syam, you have logged in. Dr. Syam, you have logged in from two systems, so your voice is echoing. We are not able to hear you properly. Request you to kindly speak from one system only.
I mean to say, can we go with low resource in the low resource setting with lower setup of investigation like CBC and CRV, not with this D-dimer and this LDH and ferritin, etc.
I will answer this question. This is a very good question. Like routinely, what we do is CBC and CRP. If CRP is high and the children is requiring oxygen, if any child requires oxygen, then you have to go for further test. And the most important test, other than CBC, CRP, will be D-dimer, because D-dimer, on the basis of D-dimer, we give anticoagulant. If the anticoagulant should be given or should not be given depends upon the result of D-dimer. LDH and ferritin, if can be avoided, but child is very sick, then it helps in assessing the severity of the disease. Routinely, CBC, CRP is important, and if child is on oxygen, then your D-dimer should be done.
You mean to say that those child who are needing oxygen, they should go with further test?
Yeah. Those children who are requiring oxygen, if minimal oxygen is required, then D-dimer will be good enough. If high oxygen is required, then you have to go to the full panel to assess the severity and the proper treatment.
Thank you.
Thank you so much. Now, for the next question, any participant? The questions can also be typed in the chat box. In case anyone has any difficulty with respect to posing the question through audible media, you can type it.
Hello, this is Krishna Kumar here. Am I audible?
Yes, sir.
Yes, I just wondered, with so much of COVID all around us, is it not that we are overdiagnosing COVID in children coming with symptoms which would have come if they had come, say, with diarrhea, vomiting, or cough, cold, etc. And just because they are COVID positive, we are associating the two together. So are we that way not overdiagnosing when the child may not be actually having the correlation with the COVID infection as such? He might have had the COVID as a bystander. Is that a possibility?
Yes, sir. I'll give the simple example today itself. A child, 10 years old child, came with a respiratory difficulty, severe respiratory difficulty. We thought it may be a post-COVID multisystem inflammatory syndrome, but it came out to be diabetic. It came out to be diabetic ketoacidosis, and her CRP was normal, procalcitonin was normal. Although COVID antibody is positive, but that doesn't mean she has multisystem inflammatory syndrome. It is just plain DKA. It is not COVID related. Like that, many children will come with diarrhea. Same, if diarrhea is there and COVID comes positive, and if CRP is normal, we can take it as a bystander. That's all. Because most of the cases of COVID infection are symptomatic. You will have a raised CRP also.
Thank you.
Thank you, Dr. Saab. Thank you once again. Any other question, please?
Yes, I have a question. My name is Dr. Gaurav. Basic question is, do we keep CRP as a marker here, as an inflammatory marker, or is it a prognostic marker, or per se a diagnostic marker for COVID? Because many patients with acute gastroenteritis or respiratory symptoms are coming with very high CRP these days. Though they are, because of the availability of RT-PCR at our centers, the RT-PCR reports are 6 to 7 days delay. Antigen tests are not coming positive. And I have admitted 6 to 7 patients of those categories. They have responded to symptomatic treatment. And generally the fall of CRP has been gradual. It is not sudden. In last 8 days, I have admitted 12 patients of similar sort. Most of the patients had gastroenteritis, which generally occur in the season, in hot season. 3 patients were having respiratory symptoms. I went for HRCT, and one turned out to be COVID on basis of HRCT with severity index of 16/25 on HRCT. So what I found it that CRP has been a very early marker in case of pediatric patients as a indicator of COVID, or you may say inflammatory indicator.
Yeah, true. CRP is a very sensitive marker, as we all know, for any inflammation in the body. It's not only the COVID, even the gastroenteritis, or if you have put a cannula, the swelling is happening, or anything, any inflammation, CRP will go up. CRP just shows there's something happening in the body. The inflammation is happening in the body. But obviously, if you have very high CRP means in children we mean more than 80. If I have more than 80 milligram per liter, then it is very significant, and we have to look for explanation of that. If it is less than 20, it's all right in children. Between 20 to 80, we have to use your own clinical judgment. But if anybody is coming up CRP more than 80, be careful and evaluate it properly.
Okay, sir. Thank you, sir.
Thank you so much.
May I interfere, sir?
Yeah, please.
Yeah.
Go ahead.
Maybe along with CRP, we can have CBC, in which we can find lymphopenia and lymphocytopenia and other things like platelet and other indicator which can help with CRP, which can indicate something which is going towards COVID.
Yeah, lymphocytosis is an indicator, but what regularly or routinely
Lymphocytopenia, I mean to say. Lymphocytosis is there in viral gastroenteritis. Okay. Right. But here will be in COVID, it will be lymphocytopenia. You have to see another issue.
Put in few words in this. We basically look at the NLR ratio, that is neutrophil lymphocyte ratio. Yeah. And it's a good idea to get a PCT also done in case of this. PCT is a very specific marker of sepsis and inflammation in the body.
The issue with PCT is it is a costly affair at a small setups.
Yeah.
It is a very costly affair at a small setup. Most of the district in our state might not be having PCT. CRP might be possible. And
NLR can
mostly-
be looked at. NLR cutoff
Yeah,
1.3.
NLR is in-
Yes, 1.3 is the
Yeah.
cutoff. More than 1.3 is considered as a marker of inflammation.
In CBC, you can have lymphocytopenia, you can have platelet count, you can have RDW. In fact, RDW is going higher up. It has a poor prognosis. So there are CBC and CRP can give most of the clear picture. Thank you.
Thank you so much. If there is any further question, we may have the questions quickly. Any further question, please?
One comment in chat box is very important, that steroids should not be misused, and steroids should never be given in the first 5 to 7 days of coronavirus infection, because first 5 to 7 days it is our immune system of the body which fights with the corona. And if you give steroid in first 5 to 7 days, your body's immune system gets suppressed and it becomes counterproductive. So please avoid steroids in first 5 to 7 days. If a steroid has to be used, it has to be used after 5 to 7 days, not before that.
Hello. Hello. Dr. Rajesh.
Yes,
Hello.
ma'am. Yes, ma'am.
Am I audible? So I want to know one thing, very basic one. So how many times we are supposed to do RT-PCR in a neonate? Like it's recommended that at 24 hours, then 48 hours, then you said 5 to 7 days, then 10 days. So how many times should I go for that?
Yeah, recently I had reviewed this because I had a problem with two neonates. The recommendation, official recommendation is within first 48 hours, you should do. But clinically, if you go, the incubation period of coronavirus is 2 to 14 days.
Oh.
So if you want to rule out for a specific, for a given baby, you want to rule out with 100% certainty, you have to do first within 24 hours, second between 5 to 7 days, and third one between 12 to 14 days. So if you do 3 tests in a baby, then it rules out 100% if the baby is not having. Otherwise, if you want to use a single test, and before discharge, if baby is getting discharged on day 3, you can do on day 2. If baby is getting discharged on day 5, you can get it done on day 4, like that, a single test.
One question, Dr. Rajesh. One question, Dr. Rajesh.
Hi. Okay, thank you.
Yes.
One question, Dr. Rajesh.
Yes, sir.
Supposing there is no facility for any test in a place where a patient is admitted for COVID, suspected COVID, do we have to wait for all the reports to come, or we should start immediately suspecting COVID? Because we should not lose any precious time for treating the patient.
Sir, very good question, because treatment of acute coronavirus infection in children is mostly symptomatic. So you don't have to wait for a result to start treatment. Whatever symptoms child has, like child has a cough, you can give a cough syrup or antibiotic. Child has diarrhea, then give ORS and IV fluid, like that. So no specific treatment is required for first 5 to 7 days. And if then after 7 days, if things are getting worse and getting oxygen requirement is going up, then you have to use dexamethasone, and otherwise it's not required. And if you want to use remdesivir in children, again, remdesivir has to be used in first 7 to 10 days, because you want to kill the virus, and then there it is important. If child is sick, then we try to get it early report. And if it is positive, you can give remdesivir if child is very sick. If child is on a significant oxygen requirement, then it is the only indication of remdesivir. It's not like that child is having fever and not feeding well, you start giving remdesivir. Remdesivir is required only for children who have got significant respiratory problem and requiring high oxygen. And other thing is for MIS, obviously, if you have multisystem inflammatory syndrome, specific treatments are there. there you have to expedite your investigation. Then only you can give IVIG or steroid. For routine acute corona, whether report is coming. Yes,
Dr.
yes.
Rajesh, do you agree that without waiting for any
Not audible.
test to be report from etc., whatever, should we start instantly taking the case as a COVID positive?
It's not. Can you repeat the question, sir?
Yeah. My question, supposing in a facility where test cannot be performed as early as possible, what we do here. So is it possible or is it okay for us to start treatment taking as COVID positive in spite of all those reports which are likely to be done and we are not able to do so?
As you told, sir, children with a symptomatic treatment only, you should isolate the child. Most important thing is you have to isolate the child from the other children. If you are suspecting the COVID, you should not admit with the other children. You should admit either in the triage ward. It's better to use in triage ward, and we should wait till the RT-PCR report comes, or then we can shift to the whether COVID ward or non-COVID ward, because COVID report, RT-PCR or rapid antigen test report is mostly important for triaging the child, where to admit in the hospital. Is not for the...
Because the RT-PCR reports are not being delivered on the same day or the next day because patient's time is lost.
That's why nowadays government has given permission even to a private hospital to do rapid antigen test with proper training and proper uploading of the reports to the ICMR. Any hospital can do rapid antigen test in their facility with the permission of civil surgeon office.
One thing, what is the role of inhaled steroids? As you said, you can give systemic steroid after 5 days or 7 days. Whether can we give inhaled steroid on or before 5 days?
Again, this is a controversial. In adults, it is now recommended. In adults, it is now recommended by guideline. But in children, we don't know. In children, it's still not put in the guideline. But if you extrapolate that, bigger children who are more than 10 years, obviously we can extrapolate the adult recommendation to the bigger children. You can give it. But officially, it is not recommended till now.
Turn to Dr. Apeksha now. Am I audible, Dr. Apeksha?
Yes, ma'am, you're audible.
Okay. So I wanted to know one thing, like in hemolytic anemias, like severe anemia, they are coming with all breathlessness, and so this part should have been included in your MIS-C, because how can you separate breathlessness of severe anemia with this thing? So COVID suspect cases, should we include those cases in COVID suspect? Because in all cases, like, they are special comorbid conditions, especially vulnerable to get these infections. So what precautions or what should be the guideline for those patients?
Ma'am, in case of, ma'am, in any patient, be it hemolytic anemia or any patient that is coming down with a case of breathlessness, COVID is the most probable diagnosis. That's all I wanted to say in my presentation, ma'am. COVID is the most and further investigation can come up with whatever pathology the child is suffering from, and the treatment can be given according to that, ma'am. So that is why I didn't include other diseases in my presentation while I was presenting MIS-C.
Madam, I will add here.
Like, this is a very common condition. Huh? Okay.
I will add here, madam, because it is an administrative problem, and because the children comes with fever and cough, like in our hospital, it is given as a guideline. Any child coming with fever or cough has to be admitted in a triage ward. So any hospital who is going to take care of the COVID children has to make a triage ward, because many children will come with the fever. You can't admit the fever patient to the COVID ward, or just if they are COVID, you cannot admit in the general ward. So there has to be a triage ward for all pediatric patients, so that after that we can sort out after the report of antigen or RT-PCR. So it is a very important administrative aspect to create a triage ward for pediatric patients in a hospital, so that the other children cannot be affected. That is very important to have a triage ward.
That is equivalent to COVID suspect ward.
Yeah, COVID suspect ward or triage ward.
Okay. Thank you.
बहुत अच्छा डिस्कशन सर आज हुआ विद द परमिशन ऑफ एसीएस सर, एंड आई थैंक ऑल ऑफ यू. आप लोग बहुत अच्छा, इनफैक्ट डॉक्टर राजेश आप मेरे को याद आ गया कॉलेज में हम लोग जब सीएमई अटेंड करते थे सर. आई कैन से कि पूरा क्लिनिकल स्टडी आज हम लोगों को करा दिया पूरा. मेरे को तो रिवाइज हो गया है क्या क्या हमने उस समय पढ़ा था, एंड आई रियली थैंक यू ऑल सर. इस तरीके की सीएमई की आने वाले टाइम पे हमको बहुत आवश्यकता है. एंड डॉक्टर राजेश और हमारे बाकी पैनलिस्ट, इनफैक्ट हमारे जितने भी डॉक्टर्स हमारे साथ ज्वाइन किए, मेरा आप सबसे अनुरोध है कि आप लोग अपने डिस्ट्रिक्ट में भी हमारी प्रेजेंटेशन, 5 प्रेजेंटेशन हमने आप लोगों के लिए डाल दिए हैं. आप लोग अपने से भी सभी डॉक्टर्स का एक बार इस तरीके का डिस्ट्रिक्ट वाइज भी अगर आप लोग मीटिंग कराएंगे, सेमिनार या वेबिनार आप लोग डिस्ट्रिक्ट वाइज कराइए, बिकॉज सेम चीज को जितनी बार हम रिपीटेशन करेंगे तभी हमारे डॉक्टर्स के मन में इंस्टिल होगा. वी नीड टू अंडरस्टैंड वन मोर थिंग इन दिस. अभी तक हम लोगों ने मेडिसिन की बात की, अनफॉर्चुनेटली हम लोग कम्युनिटी मेडिसिन की बात नहीं कर पाए, जिसकी हमें बहुत आवश्यकता है इस समय. बिकॉज जिस तरीके से हमने फर्स्ट और सेकेंड वेव में देखा, केवल 2% केसेस होते हैं जो हमारे पास आएंगे. 98% केसेस घर पे ही रहेंगे या फिर एसिम्प्टोमेटिक रहेंगे, या जो जिसको हम सुपर स्प्रेडर कह सकते हैं. तो मेरा आप सबसे अनुरोध है कि आप लोग अपने स्तर से तो क्लिनिकल मैनेजमेंट के बारे में बाकी डॉक्टर्स को बताएं. इनफैक्ट कोशिश करें कि हमारे जो एमबीबीएस डॉक्टर्स हमारे डिस्ट्रिक्ट हॉस्पिटल्स में हैं, हमारे एमओआईसी साहब लोग हैं, अपार्ट फ्रॉम जिस तरीके से हम लोगों ने फर्स्ट और सेकेंड वेव में सर्जरी, मेडिसिन, ऑर्थोपेडिक, आई, ऑप्टो, इन सभी यूनिट्स को यूज करके, क्योंकि एट द टाइम ऑफ क्राइसिस हमें डॉक्टर्स नहीं थे, तो उस समय हमने सबको यूज किया. तो इस बार अगर एक तरीके की, जैसे आप लोग सीएमई हम लोग आज किए हैं, हम लोग सभी लोगों के साथ, हमारे सारे डॉक्टर्स के साथ डिस्ट्रिक्ट वाइज करें, सबको एक बार सेंसिटाइज कर दें कि अगर कोई पेशेंट आता है तो किस तरीके से उसको हम लोग ट्रीटमेंट प्रोटोकॉल दे सकते हैं. और बहुत सारे, क्योंकि आम जनता को अभी आपको सेक्रेटरी सर बताएंगे कि किस तरीके से हम लोगों के पास बड़ा प्रेशर आता है कि जो झोला छाप डॉक्टर्स होते हैं उनको अलाउ कर दिया जाए. कुछ डिस्ट्रिक्ट में आपको पता भी होगा कि हम लोग उनको यूज करने की सोच रहे हैं बिकॉज हमारे पास कम डॉक्टर हैं. बट असेसमेंट अपने स्टेट का किया तो वी आर मोर देन 10,000 डॉक्टर्स, आयुष डॉक्टर्स, सब कुछ मिला जुला के अगर हम देखते हैं, तो अगर हम अपने ही डॉक्टर्स जो हैं उनको अगर ट्रेन कर दें, तो जो अभी बिहार ने वाला एक्सपेरिमेंट भी किया है, आप सबको पता होगा कि झोला छाप डॉक्टर्स को, अल्टरनेटिव मेडिसिन वाले डॉक्टर्स को लिया और मोर्टेलिटी रेट सडनली हाई हो गया. तो ये हम लोगों ने डिसीजन यही लिया था कि हम अपनी तरफ से किसी को कुछ नहीं बोलेंगे, बट वी नीड टू अंडरस्टैंड, आप सब लोगों को भी समझना पड़ेगा, जब तक हम अपना ज्ञान दूसरों को नहीं देंगे, जब तक हम बाकी अपने डॉक्टर्स को ये वाली बात नहीं बताएंगे आने वाले पीरियड 2 महीने में, तब तक कहीं ना कहीं लोग पुनः उन्हीं लोगों के पास जाने लगेंगे. तो सर मेरा आप सबसे अनुरोध है कि जिस तरीके से आज हमने क्लिनिकल मैनेजमेंट सीखा, एक कम्युनिटी मैनेजमेंट का भी मैं डॉक्टर राजेश सर से रिक्वेस्ट करूंगा, और आप सभी लोगों से मैं रिक्वेस्ट करूंगा कि अगर आप लोग कोई पेपर बनाना चाहें कम्युनिटी मैनेजमेंट कैसे करें. होम आइसोलेशन का बहुत अच्छा इशू मैडम ने रेज किया था, तो होम आइसोलेशन में हम लोग क्या क्या एक्सपेक्ट कर सकते हैं, क्योंकि जो छोटा बच्चा होता है, आई एम श्योर हम सभी लोगों के घर में, तो 10 साल तक का बच्चा तो पेरेंट्स के कंट्रोल में नहीं रहता, उसको एक कमरे में होम आइसोलेट करना कितना मुश्किल है. आई एम श्योर ऑल ऑफ अस विल अंडरस्टैंड. हम सबको पता है कि हम अपने बच्चों को एक कमरे में 5, 6, 7 या 8 दिन नहीं रख सकते, तो कैसे उसको हम स्ट्रेटेजाइज करेंगे. स्टार्टिंग में ओपनिंग रिमार्क में भी हमने आप सबसे अनुरोध किया था, सारे हमारे गवर्नमेंट डॉक्टर से, कि चाइल्ड फ्रेंडली हॉस्पिटल इनिशिएटिव, ये एक नया लेटर आप लोगों के लिए एसीएस सर की तरफ से जाएगा. मीनवाइल अगर आप लोग उसमें कुछ आइडिया देना चाहते हैं कि कैसा हॉस्पिटल हो, किस तरीके का पेंटिंग करना चाहिए, ताकि बच्चा जो डिस्ट्रेस के समय आए, क्योंकि हो सकता है कि हम लोग अपने नजरिए से देख रहे हो, लेकिन आपको पता हो कि डिस्ट्रेस के समय में किस टाइप के कलर्स बच्चे को पसंद आए. तो हम लोग चाह रहे हैं कि एक ऐसा होलिस्टिक प्लान रहे, ताकि नॉट ओनली दिस वेव, अगर इफ इट कम्स, बट आने वाले 4-5 ईयर्स के लिए हमारे पास एक इंफ्रास्ट्रक्चर स्ट्रेंथन हो जाए. दिस इज द अपॉर्चुनिटी फॉर अस. कोविड हमारे में एक आपदा में एक अवसर है कि हम अपनी मेडिकल फील्ड को अच्छा कर सकें. ये आपदा में हमारे सभी के लिए एक अवसर है कि हम अपने आप को और अच्छा प्रूव कर सकें, और हमारी जो भी कमियां हैं उसको हम दूर कर सकें. विद दिस आई रिक्वेस्ट अवर एसीएस सर सर आपका मार्गदर्शन बहुत जरूरी है। आप सबको बताना चाहूंगा कि थर्ड वेव का पूरे इंडिया में फर्स्ट वेबिनार शायद से स्टेट लेवल ऑफिशियल के साथ हो रहा होगा, एंड इसका ऑल क्रेडिट शुड गो टू एसीएस सर, जिन्होंने विजुअलाइज किया कि इससे पहले कि कोई व्यक्ति हमारे घर में आए हमें उसकी तैयारी कर लेनी चाहिए, जो हम पूर्व में नहीं कर पाए थे। तो मैं चाहूंगा एसीएस सर को कि सर अपने आइडिया सबके साथ शेयर करें। और सर से ये भी रिक्वेस्ट रहेगा, क्योंकि पिछली बार थोड़ा सर का ऑडियो क्लियर नहीं हो पा रहा था, कुछ कुछ बातें सर की कट रही थी। तो सर इफ यू कैन रिपीट ऑल्सो, तो इट विल बी हेल्पफुल टू ऑल द डॉक्टर्स हु आर प्रेजेंट विद अस। So over to you, sir.
Umesh, first of all, I thank all the participants and especially the panelists for making informative presentation, and the interaction which you all had. I think it must have benefited all the doctors, and the points which have been raised by Bhuvnesh as far as the management, the medical management and the administrative management and the social management that is expected to be undertaken when this wave strikes. So we have to visualize the whole scenario that may come up before us. What is the scenario in the hospital? What is the scenario outside the hospital? What is the scenario in the society? And accordingly, we have to prepare ourselves mentally as well as infrastructurally. So the time is now when we plan for it and we are making detailed plan. I would expect this type of webinars be organized at regular intervals, so that those doctors who have not been able to participate, they also participate, and those who have participated, they disseminate this information. The PPTs have already been shared, and you can make use of those PPTs, and if you have any queries, then our expert panel is always available. We have set up a expert group, and we would be continuously interacting and coming up with solutions. And the strategy to handle this probable wave, I think we have discussed in detail, and we will continue it further. With this, I thank you all, and we'll meet again very soon when we have the national webinar in which participants from the eminent participants from the country also would be participating. Thank you very much. Thank you.
Thank you, sir. Thank you all. Thank you very much. Thank you, sir.